Welcome on behalf of the Centre for Digital Transformation of Health to our Clinical AI series. We have a great speaker today who Wendy, the director of our centre, will introduce in a second. So this is going to be about an hour. We'll have, I think, about 40 to 45 minutes of presentation, and then there will be an opportunity to ask questions. And please do ask questions if you have them. It's a great way to get a discussion going. We have coffee and tea, and there'll be a light lunch afterwards. So without any further ado, I might hand over to Wendy to introduce Dr. Luo, our speaker for today. Thanks, Wendy.
Yeah, thank you. Welcome, everyone. We're really lucky today to have Dr. Yuan Luo with us to speak about multimodal, proactive, and collaborative AI to power a learning health system. And so just one second, I got to shut my door. Okay, sorry about that. So Yuan got his PhD in 2015 from MIT. And so that's 15 years after I got my PhD. And I've been a mentor to him over time, but I really look to him for just amazing accomplishments. And he's been a great example of, he just has really always sought me out at AMIA, our main conference, and asked for time to really ask questions about his research and then his leadership opportunities and career opportunities. And I think it's a testament to be able to, proactively build a network around yourself. And so those of us who are shy and a little bit socially anxious can look to Yuan for his example on that. I think it's really effective. So of course I watch him very closely, and his research is really inspiring. So Yuan is currently at Northwestern, and he works on machine learning, natural language processing, time series analysis, integrative genomic analysis, and big data analytics. And he has a focus on medical and clinical applications. He's the chief AI officer, which is a fairly new type of position in the world at Northwestern University Clinical and Translational Sciences Institute, and at the Institute for Augmented Intelligence in Medicine. He's a warm, wonderful person, and thankful for your sharing your time while you're in a hotel room in New York on this evening in the US. So really looking forward to your talk, Yuan.
Thank you so much, Wendy, for the great introduction, and I'm very fortunate to have you as a mentor. So today we're going to talk about our recent work in terms of building a multimodal, proactive, and collaborative AI to power a learning health system. So I know there's a lot of terminology there, and I want to take some slides in order to unpack what it really means. So first, let's take a look at the current reality of the incoming data sources that we need to deal with at a daily basis. So if you look at the health system, they're generating tremendous amount of data, not only in terms of the quantity, but also in terms of the diversity and in terms of the sources of the modality. You have medical imaging data, you have structured EHR data, time series actually, and you have unstructured clinical notes. You have the molecular data, including those genomic sequencing data, and even some of the emerging technologies like spatial transcriptomics. And those data, they each tell a aspect of a patient profile. It's only until you combine all of them and to triangulate the different sources of evidence that you can better understand the underlying disease mechanism and also to inform targeted therapy. But to do that, to combine them, you actually need multiple specialties collaborating together effectively so that they can complement each other in terms of the understanding. And this is not an easy thing to do. This is why we need collaborative healthcare for AI for healthcare. And another crucial aspect of making multimodal AI for healthcare really works is in terms of the proactive AI for healthcare. And here's what I mean. if you look at traditional AI for healthcare and for general domain systems, they are mostly reactive to human experts' input. And they took whatever the human has feature engineered and whatever model that humans ask you to try on the sort of hypothesis space. But this kind of system, this kind of paradigm always suffers from the issues of data shift, data bias. So this problem has been exacerbated in terms of the pandemic, where we have a constantly mutating virus that is affecting different populations on a daily basis. So how are we going to be able to deal with this fast evolving landscape? Of course, the conventional reactive AI system paradigm no longer works, but we can evolve it so that it becomes more proactive. Proactive in the sense that we can automate the feature engineering, which is already largely done with all this deep learning systems and attention-based models. But on the other hand, I think what's even more crucial is to automate this data collection so that the model itself can tell you where the weakness of the data lies and where you might want it to perform augmentation in order to fight the bias issues or even address some of the missing data issues. And humans, they have limitations in terms of their bandwidth of dealing information. So imagine that you have hundreds, if not thousands, of variables that are coming at the same time. You might not have a good grasp on where some of the bias may lies, where some of the data shift may happen. This is where exactly those proactive machine learning system, AI system can tell you in terms of informing on the data weakness and guide your targeted data collection and to augment data preparation. So this sets a premise of the proactive and collaborative framework that we need to approach with AI for healthcare. And to make that happen, we actually need to go with much more basic things. One is to build streamlined and interoperable and scalable systems in order to democratize the access of the information in the health systems to all of the researchers. That includes the resources and that includes the tooling. So here I'm just using NLP on clinical notes as an example. People may be well aware that clinical notes, they have a lot of the useful healthcare information that are locked in the text, but physicians typically do not have the bandwidth or the expertise to launch an NLP system, natural language processing system, in order to extract those information from the notes and put them in a form that is amenable to machine learning models. So what we are doing at the health system level is what we call bulk NLP. We took all the clinical notes from the enterprise data warehouse and we process all of them, extract those useful medical concepts. Let's say if you're interested in pharmacovigilance, we can give you the medications and also the associated adverse events. And moreover, we put them in a accommodated model table so that different institutions can refer to the same kind of schema, the table structures. And when you write queries, you only need to query those accommodated model tables, and you don't need to launch NLP system from scratch anymore, which is a time-consuming, laborious, and often error-prone approach. And with that kind of resources, we make them accessible to all those physicians in the health systems, in the medical school, those researchers. And this has greatly accelerated research because people can have access to previously locked up information much more easily. And we didn't stop at that point. We actually went further in terms of making the information integrating them from different multiple institutions. So here's an example of how we approach the integration of data resources. And we recognize the need that single health systems may have biases in terms of the racial ethnic profiles or geographic diversities and also practice diversities with the patient population, with how those procedures were done at different institutions. And it's crucially important that we pull together data from different academic medical centers. If you reflect on the differences between general domain AI and healthcare AI, we lag behind compared to general domain AI. And I think one of the very important factors is because we do not have this large and diverse benchmark data set such as the ImageNet or the Wikipedia corpus uh, for the general domain AI development. And this is exactly what we are trying to create here with the flagship data set that is diverse in both the racial, ethnic, gender, and also geographic and medical practice differences. And with this data set, we created this pooled cohort, and then we're about to actually share the data set with the research community very soon. And then with this data set, you're going to be able to use it as a benchmark resource to develop and constantly improving on all those machine learning models so that to make sure that they not only perform well, but also generalizable across all those heterogeneous dimensions. So this is on the resource building front end. We not only try to make resource more accessible, let's say locked in those clinical nodes, but also we wanted to make those resources more diverse. So both in terms of depth and in terms of the breadth, this is where we're going in terms of building the resource. And then similarly, we also wanted to make available or democratize the tooling to the research community. So people nowadays, they talk a lot about large language models, and people are well aware of the development of the GPT-based models. But in terms of large language models, it actually goes back further. So even more than 5 years ago, there was the invention of transformer, including BERT-like models. And with those models, we can develop tools that perform different kinds of text manipulation tasks much more easily. For example, some of those tasks are listed here: natural language inference or name identity recognition, try to recognize the medical concepts, or question answering in the medical domain, or text classification, give a document, try to classify whether the patient has a certain disease or not. Those kind of tasks, they can be uniformly handled by these large language models given proper prompt and, well, in some cases, given proper fine tuning. And this is where we wanted to delve deeper in building some of those models and addressing some of the challenges. One of the challenges that we address head on is in terms of the length of the tokens that those large language models were able to take. The conventional BERT models is subject to the limitation of 512 tokens, but we all know that clinical nodes can go much longer. And so how do we incorporate better attention-based models and to be able to accommodate longer text sequences? And this is why we were leveraging some of the sparse attention mechanism and build the models, clinical BERT and clinical long-former, and also clinical big BERT. And we conduct a comprehensive evaluation of those models on the different tasks, all the 10 tasks that are listed here in the middle of the panel. And our model, of course, performs better than the state of the art. But instead of elaborating on our own results, of course, since the paper is published, our results, of course, beat many of the state of the art. But I wanted to mention a clinical study using our large language models to adjudicate heart failure hospitalization from discharge summaries from entirely different and separate groups. I think in this case, it's at MGB, Mass General Brigham, at at Boston. So their result is as listed here in the screenshot of the tweet that they posted. It's actually a perfect underwriting of our contribution, and it's absolutely rewarding to see another independent group's acknowledgement of the utility of the system that we built. And we attribute these improvements to the pre-training stages of the clinical long-formers and clinical big bird that leverages sparse attention models. And those models can learn more long-term dependencies by extending the sequence length limit from 512 tokens to over 4,000 tokens. And this allows them to learn a richer contextualization of clinical concepts and perform better in various clinical NLP tasks. And so we have developed also tooling for improving on the interoperability. And in this case, we're leveraging GPT-based large language models. And in this particular application, we think about the question of converting the clinical nodes to FHIR resources. So for people who are not familiar with FHIR, it stands for the Fast Healthcare Interoperability Resources. It's a standard that can be used for exchanging EHR data between medical institutions. It's actually can be an alternative to the combinated models. The combinated models, where people put everything in the centralized database that are subject to the common schemas. And you need to do a lot of the data mappings. But the FHIR resources allows people to sort of exchange information on a more federated way. And this standard was created and maintained by the Health Level 7 International Standards Organization. I'm going to give you a concrete example of what it looks like to translate from a clinical node sentence into a FHIR resource. So in this sentence, it specifies medication with its form, tablet, and its dosage, and its route through mouth, and its indications for constipation. And if you wanted to generate a FHIR resource, basically you can think of it like a JSON format that encodes the different sources of the information from the concept of medication to its form, to its route and reason. So in order to generate this FHIR resource from the sentence, you need to perform a series of NLP steps named entity recognition, relation extraction, to really classify which is the reason for this medication, which is the reason for another medication, and standardization because terminologies can vary. You can say different things, let's say CD45 and leukocyte common antigen. They actually mean the same thing, but there's not a single word overlap of those of those phrases in verbatim, right? So you need to map them into the same concept. And in other cases, you also need to calculate the equivalent amount of the dosage. And of course, you need to format that into the JSON-like structure. This series of NLP steps can be cumbersome, labor intensive, and also each of them is error prone, and then you are looking at compounding the errors on top of each other. So it's kind of like a nightmare situation to work through, and it's very, very difficult. But if you look from end to end, it's given a sentence generating a JSON-like structure. It's basically generative modeling, right? And why don't we just try those large language models to see if we can properly prompt it so that it can achieve the task that we wanted at acceptable, at least the reasonable accuracy and speed. And so this is what we did. And we were able to demonstrate the efficacies in terms of the comparison between the state-of-the-art system as listed in this figure here. We compared to those SOTA systems in both academia, the NLP to FHIR paper that was published just a couple of years ago, and also the commercial system like Google's Health and natural language API. And we were able to show that those large language model-based FHIR resource generators were able to outperform both commercial and academic SOTA system. And compared to other large language models, we made the comparison between the Llama 2, which is 70 billion parameters, and Falcon, which is 180 billion parameters. And GPT-4, this one has, I think, 1.7 trillion parameters, on that order of magnitude. And as you might imagine, that GPT-4 performs the best. And here, I think the size does matter in terms of the accuracy and also in terms of the speed. And for more details, you can refer to the papers that are about to come in EJM AI, I think probably next month. So we have talked about in terms of building the resource and the toolings for people to access the data, and then for people to access the data in an interoperable way, integrating data sets from different academic institutions. And now, once you have the data, you couldn't help but pay attention to its quality. And we have noticed that healthcare data is often subject to different quality issues, but many of them boils down to either missing data or bias issues that frequently surface as themes of the issues that we need to address. And so this is why we have also developed toolings for missing data imputation and for modeling the bias, whether the bias is explicit that we already know or it's implicit that is not known before and we need to expose that. And the benefit of developing those toolings is that you can, with imputation models, you can fill in those missing entries and make those more cases will be proper to use for downstream AI machine learning tasks. And then with bias modeling, benefit one is you expose those bias so that people can take them into consideration in their decision process. And benefit two is that you can actually build models that address or mitigate those biases. And we were able to show that by integrating, for example, the social determinants of the health factors, you were able to not only improve on the equity of the machine learning models, let's say it performs equally well on both Black patients and white patients, but also we were able to show that it can actually improve the overall performance. So it's a little bit counterintuitive to what one might think of as a trade-off between the utilitarian perspective versus the egalitarian perspective. So here, we actually showed that you can achieve both with the addition of those social determinants of the health factors. And this has greatly improved the quality of the data and making real-world data more amenable to generate real-world evidence. So we often use these words interchangeably, real-world evidence, real-world data, but they actually mean different things. And there is the big step to come from real-world data to generate real-world evidence. And then with better quality data, it gets us one step closer to really generate those insights for real-world evidence in order to make point-of-care recommendations. And once we have the good quality of data, probably one of the immediate things that we can do that can be deployed in the health system is to operationalize and better operationalize the diagnostic testing and also staffing on the floors so that we can improve the cost efficiency of the testing and also to improve the throughput of the hospital. Now, for example, in terms of the diagnostic testing, you can approach this as we did with reinforcement learning on the utilities of the different panels of the test, because some of the panels, they are more expensive, and other panels, they are probably smaller panels that are less expensive. And often the clinicians may rely on their reflexive judgment to order one test panels routinely, but there is actually, as we observed, great space in terms of optimizing this process so that you can ensure that with the enough size of the test panels, you can get the information that you need. So you never need to overspend in terms of going for a bigger panel, but that only generates the same amount of information as the smaller test panel. And we were able to show that with reinforcement learning, we could approach this balance effectively, maintaining basically the same accuracy of the test in terms of the diagnosis accuracy measured by F1 score. But in terms of the cost, we will show that we can achieve up to 85% of the reduction in terms of the diagnostic testing. And we have been expanding on this type of approach to look at the resource planning for, let's say, when you're in a critical care crisis that you need to allocate the different, let's say, critical care resources like ventilators to the patients. How are you going to do it in a way that is both equitable and also saves the maximize the numbers of the lives that you're saving? So that's also a question that can be modeled with reinforcement learning. Of course, in those cases, you need to incorporate those fairness objectives in addition to those utilitarian objectives like the total numbers of the lives that are saved. But we were able to show that by integrating these two objectives together, you can plot basically the Pareto frontier that allows the user to have a more informed trajectories of decision making. So that is in terms of utilizing the data set that we provided of assisting the operations of the health system. And of course, the data set that we have built, those strategic flash data sets can also be used to inform the understanding of the complex disease and inform targeted therapy discovery. And here is an example that combines those different modalities of the data in order to understand autism, which is the hereditary disease, but it's also very complex. And to date, there's the etiologies for the understanding about the etiology only covers the single-digit percentage of all those cases. And so what we did is to combine all those different data source modalities as shown on the left panel here. So here you have the transcriptomics data that depicts the axon, their expression during the brain development over the trajectories from the newborns to adulthood. And that allows you to trace the activities of each genes and actually its axons when they were active in terms of the brain development. And we also incorporated information in terms of those genetic mutations for autism individuals. We didn't just incorporate their own mutation, we actually compare their mutations with their siblings. And in this case, you can look at panel C, where we have two types of families. One is simplex families, where you have a family with one child with autism and another without autism. So you have the proband and sibling. And then you also have multiplex families where you have multiple children within the same family or all are affected with autism. So you can think that if you filter those mutations that are differential between the proband and sibling simplex families and also retain those that are co-occurring with all those members in the multiplex families, then you're basically zooming in on the most likely causes of autism. And then you can triangulate that set with the brain development and then see which of the axons are impacted. One thing with the direct triangulation is that we still run into the power issue, because if you think about all those axons, there are tens of thousands of those axons, and then just sifting through them will need tens of thousands, hundreds of thousands, if not millions of the patients, and we of course don't have that number. And in this case, we could leverage this transcriptomics data in order to identify those axons that are collectively co-regulated during the brain development, meaning that if you look at the trajectories as plotted in the panel A here, they are more or less synchronized. And then you can reason that if mutations hit those axon clusters, they will have a more synchronized impact on the likelihood of developing autism. And this has effectively boosted up the power of this study. And this allows us to generate a hypothesis like what's shown on the right panel here, and which is related to the dyslipidemia issue. And you have LPL, lipoprotein lipase, that digest the triglycerides in the triglyceride-rich lipoproteins. And these LDL receptors, they bind the extracellular LDL particles, and they internalize them to the cell for their various downstream consumptions. So what can we expect that when those LPL and LDL receptors are dysfunctional, then you would expect the triglyceride digestion and also the LDL internalization would be affected, and we will be left with higher levels of the triglycerides, LDL, and cholesterol in the blood. And then you can take that into the EHR data and the health insurance data to validate that this is indeed what we observed from very large cohort. And it's really the integration of those multi-modal health data that allows us to triangulate on those different pieces of the evidences that can give us insights into a complex disease like autism, and something that might be attractive points for early intervention, because right now, autism is still diagnosed on a behavioral basis, and by the time of the diagnosis, a child might have already been 2, 4, or even 5 years old, and critical intervention windows have already gone past. Imagine that your early biomarker-based screening can screen and generate signals for those individuals when they were just born, and the intervention window can be brought much earlier. So this is why this kind of study is very beneficial, and it's basically made possible by the multi-modal data stacked together. And nowadays, of course, we have emerging technology like spatial transcriptomics, and this is where we are also going deeper in terms of even giving better and more contextualized insights about the disease mechanism. So for people who are familiar with single-cell RNA-seq data, spatial transcriptomics, you can think of it as a single cell plus the spatial context of the tissue. It tells you where, let's say, CD4 cells and the malignant cells, they're closer, how their expression will be differ from when they are farther apart. So it tells you the spatially variable genetic expression, and it tells you the cell-cell interactions that reflect the disease mechanism. And we wanted to create a one-stop shop so that people can just hop on to our resource website and then perform those meta-analysis and mega-analysis on those spatial variability, cell-cell interaction, and differential gene expression analysis, and even drug discovery. And to this end, we have been working on this project for over 3 years and curating over 2,700 samples across 11 species and 40 tissue types, and ranging among 11 spatial transcriptomics techniques. And the resources that we have created has allowed discoveries of very interesting mechanisms of diseases like cancer and cardiovascular disease. So in this slides, what we are showing here is a axis that's characterized by two distinct pathways. One is associated with CXCL, and that's typically associated with the immune activation and the prognosis of cancer. And another one is associated with the SPP1 pathway, that's secreted phosphoprotein. And they are typically associated with the tumor progression and metastasis. So in this case, we're showing that the macrophages that are CXCL16 positive, and they interact with CXCR6 positive CD T cells. And this indicates a more immunocompetent anti-tumor activity. And then in turn, those T cells that are CXCR13 positive, they interact with CXCR5 positive B cells and CD4 T cells. And this indicates the involvement of the B cell recruitment that is downstream and the lymphocyte infiltration, and that's even more immunoactive microenvironment. And on the contrary, those SPP1 plus macrophages, they interact with integrin alpha V that are present on endothelial cells, fibroblasts, and malignant cells. And they are involved in the functions of cell adhesion, metastatic seeding, and tumor outgrowth and metastasis. And as you can see, this axis of the CXCL pathway activity and the SPP1 pathway activity, it sort of serves as a barometer of how much of the immunoactive microenvironment is functioning in terms of fighting the tumor versus how much of the pro-cell adhesion, pro-metastasis pathways is functioning in terms of trying to promote the tumor and growth. And so this kind of mechanisms can give you insights for finding some druggable targets. And this is what exactly we can do with overlaying the protein-protein interaction information with the drug compound and target in interaction so that we can overlay those information and tells you that where those compounds could be more effective in terms of reducing some of the differential expression in those druggable targets. And we experimented this with the COVID-19 disease and used that to generate some of the hypotheses for drug repurposing. And in those cases, we're identifying carvedilol, as shown in the right panel here, as a candidate. Then we sort to use the EHR data set in order to validate its clinical efficacy using an emulated clinical trial. And in addition, we performed a wet lab experiment of titrating the effective dosage versus the toxic dosage using a human cell line that's infected, human lung cell line that's infected with the COVID-19 SARS-CoV-2 virus. And in this case, you can see there's actually a very noticeable window between the effective dosage and toxic dosage, giving you a safe zone, that Goldilocks zone, that you can properly dosing this drug to reduce the severity of the COVID-19 when using this drug. And so this kind of information that is provided in order to inform this targeted therapy, which will be quite useful, especially when you are able to combine those molecular information with the EHR information that you can integrate together. So with all those information that is both diverse and also broad in terms of its data modality, and also evolving in terms of the longitudinality of the data, we are dealing with an ever increasingly complex landscape of the systems that is to be used to analyze this kind of data. And this is where I see the need for AI to complete its own industrial revolution. So think about the original industrial revolution and think about the Model T on the assembly line. It's basically the modularization and standardization of the task that brings the otherwise complex process into something that is more manageable and actually breaking down to the biteable pieces that people can internalize them as muscle memory. And this is really important so that we can engage the entire society, because now each individual only needs to master one single piece of the assembly line step. And in the case of modern AI, it's not an assembly line, it's actually an assembly network. As you can see, we have networks of the tasks that involve computer vision, text mining, and then to the higher level task of drug discovery. And there is the complex networks, but if you can break it down to the modular steps that are easily internalizable into the muscle memory of any individual, then we can engage the entire society to perform this kind of coordinated collaborative learning. And then we can learn this on a continuous basis so that we can inform each other of the weakness of the current model and to feed the information to power the loop, the feedback loop of the proactive AI paradigm that I mentioned before. So if we can do that, I think we have a very promising future in terms of grounding some of the AI techniques, multimodal AI techniques for healthcare, for complex tasks such as healthcare. But in order to do that, it's not enough to just have the resource and the tooling to have those different models. We actually need to grow the next generation workforce. And this is why we have launched some innovative education effort. And the first one that I want to mention is called AI for Health Clinic. And this stems from the observation that clinicians and AI scientists, they often don't work well with each other. And you hear AI proponents saying that AI is going to replace pathologists and replace radiologists, right? And then clinicians, sometimes they also have their cynicism or at least the doubt towards AI system. So we think in order for them to work really well, they need to go hand in hand from idea inception to the debate on the solutions to actually implement them, deploy them, and through continuous monitoring after deployment. And this is why we created this environment to allow them to cross-pollinate each other from the idea inception of addressing a clinical challenge, and the AI scientists can jumpstart clinicians by providing the technical expertise, and the clinicians can help the AI scientists avoid the trap of throwing the model to the data. And by inviting each other's perspective to enrich their own, they can ensure that they have good rapport, understand each other, and then to continuously make relevant model contributions that are meaningful to clinical applications. And this has not only leads to federal and foundation funding, but also to industry partnership in terms of the model development and deployment. And the next thing that we did is sort of even broadening the scope more, because we realized that the need to engage the entire society in terms of the work of AI for healthcare, because you have not only the researchers, but also the staff members, the hospital administrators and clinicians, the patients. And it's crucially important to let every one of them to have at least the intuition of what it entails to use their model, the AI model for their care. And this is why we were creating this healthcare AI forum. And the format is to have biteable chunks of the video presentations, let's say 5 minutes or 10 minutes, on a recent state-of-the-art system that is either published as a paper or released as a commercial system. And then we encourage the people to gain an intuitive understanding and with the takeaway message of how that could benefit their own use and their own clinical challenge without delving too much into the underlying mathematics. So this has the benefit of crowdsourcing in terms of educating each other so that we can keep up with the constant and fast-paced development of AI for healthcare. Because right now, if you just look at the amount of the literature growth, it's exponential, and then it's beyond any single expert's capability in terms of keeping up with all those published researchers. But through this kind of crowdsourcing approach, we can ensure that the collective intelligence around this matter stays relatively up to date. So with that in place, I think we really have the hope of, with leveraging those toolings that we built for answering the analytical challenges of the multi-modal AI and machine learning system. And those toolings were constantly being refreshed based on the flagship data set that we can create in order to engage the entire research community to contribute and then to improve the model. And we can also engage the entire society of leveraging their own expertise in these modularized tasks so that collectively we can form this assembly network that will also be proactive in terms of giving us the information about where the weakness of the data lies so that we can engage that part of the experts and working with the model to constantly refreshing and improving on the system and improving on the data augmentation and targeted data collection. And most importantly, I think it's the building and creation of a cohort of versatile talents from the diverse backgrounds. So the kind of educational novelty makes it possible to do this, and the kind of industrialized formation of the AI for healthcare makes it feasible because now the education needs to happen at a modular pace, and it's possible for people to become an expert in its own modules, right? So then we can collectively maximize the impact of the data resource and the models that are trained on them to improve on the healthcare practice and also to ensure that the patient gets the maximum benefit. So with that, I wanted to thank everyone for your rapt attention and close with this open invite on having us joining forces and work together and bringing this to a whole new level. I hope something that has that I mentioned has provided good food for thought, and I'm open to questions.
Thank you so much, Dr. Luo. We have a few minutes now to take questions, both in the room and online. So I'd like to open. Does anyone here have any questions they'd like to ask? Please.
Hi, thank you very much. That was very interesting. I'm Vlada. I'm a postdoc here with the center. I do applied machine learning. I really liked your the overview of what you did for the multimodal machine learning, where you look at the EHR and claims data, but you also look at the omics data. What do you think from the infrastructure perspective for an organization, maybe specifically for a hospital, are the key requirements, the key things to happen to focus on to enable such work?
Right, so that's a great question. And so this kind of multimodality really works best when you have the different modalities data all on the same patient. That gives you the best power. But even if you don't have that luxury, sometimes you could still do late fusion in terms of you extract the information, those insights from each data modalities, and then merge the insights instead of the data. So from the infrastructure point of view, I think institutions can try to strive to create more and more, add more and more patients with multi-modal data. And to that end, I think initiatives like Emerge that has the data set of both genetic data and the EHR data, and also all of us, which is sort of prospectively recruiting patients and like genetic data and EHR data. I think those are great examples, but I think we need more, and not only in terms of the more patients covering more disease, but also in terms of the more modality, because really it's a complementarity of those data modality that offers the powers, not just in the sheer size. And so once you can do that, create more and more of the patient, add them to the cohort, that will really accelerate the model development for trying to mine patterns from those early phases of analysis, because some of the modalities, they can also cross-validate or cross-informing each other. And then if you have more of their patients that have those kind of cross-validation, cross-information, that can benefit your model training. And this would be very important, especially if you want to train foundation models on combining those different modalities. And I think institutions need to create this kind of infrastructure. And of course, this is not just I think it's beyond the capacity of each single institution. Then this is why we need more effective consortiums in approaching this goal.
Thank you. So we have a few people who have hands up online. Ashley, I'd love you to share your question.
Muted.
You're muted.
I think actually you're still muted.
Oh, I can't unmute.
All right, Ashley, while we...
Thanks very much. I'm now unmuted by administration. Thank you so much. Great presentation. I was asking on that level, following from Vlada's question, what for working for especially EMR data, do you have any particular standards to try and maintain data quality for data labeling to allow this type of multimodal integration, especially for health data? And what level of information and detail do you actually need for this to be successful?
So I think you were asking multiple fronts, and one I think is in terms of the metrics for data quality, and two, I think you were asking for the data labeling evaluation. And so typically for data quality, that spans multiple dimensions. And of course, the interoperability that I mentioned is one, because you really need to have those multiple institutions' data coming together, and then you will be able to use them in an interoperable way so that you can really benefit from the added diversity and also the size. So with that, I think models like OMOP, those combinated models, have their own series of the metrics that you can use in terms of modeling quality on that front. And in terms of the data annotation quality, that's a great question. So traditionally, I think people have been leveraging on those statistical measurements like kappa scores to measure if you were using more than one annotators to label the data, how consistent they are. And that's sort of a measurement of intrinsically how difficult and how consistent or integral that kind of labeling would be. But nowadays, since people have also paid attention to this data shifting issue and data bias issue, and then with this annotations, you will also need to look at the potential biases that's encoded in this annotation, because we don't want the hidden bias that are perpetrating into our models. Like you saw examples like if you write statement in gender neutral language of someone is a scientist and someone is a nurse, and if you write it in a gender neutral language in let's say in Turkish language, and then ask Google to translate it to English, and then suddenly the Google translator will introduce gender to he's a scientist and then she's a nurse, and so that kind of bias would be perpetrating into the model, and that source was actually from the labeling of the data, right? So you wanted to minimize this kind of biases that's in the data, and there is a whole series of the metrics that are associated with this kind of bias in the labeling of the data.
Does that answer your question, Ashley?
I'm so sorry. I was just trying to unmute myself. So
Yeah.
thank you first, Dr. Luo, for your presentation. So as you just mentioned about how do we use the large language model to apply on the fair text. So I wonder, have you ever encountered any challenges of such a transformation from like the FHIR to a clinical text, or from the clinical text into the FHIR, compared with the traditional NLP approaches?
So that's a good question. And you were asking both directions. So right now we were mainly evaluating and experimenting with the from clinical text to FHIR resources, because that's I think in greater demands in terms of the actual usage. And even there, we come across challenges of let's say you generate those medication-related FHIR resources, and in certain cases, when we find that it's harder to generate properly the dosage because that involves the numeric inference, which is probably more difficult for GPT-based models. And there you probably can imagine that you use true augmented generation, or even use a hybrid system that you have a plugin that deals with those mathematics inference. And then about the reverse direction, so it's an interesting question, and I've known people that seems to be wanting to experiment from given a few concepts or given a few of the FHIR resources that can you generate synthetic nodes that captures the basic profiles of the patients and in a realistic way, and then how effective those synthetic nodes are. So this is actually an active project that we are pursuing, and the idea would be if, let's say, we could extract those medical concepts from the original clinical nodes, then we could ensure that those medical concepts never has any PHIs. And this would be very safe in terms of the patient security point of view. And then could we generate the synthetic nodes that are based on the series of the medical concepts and make them as realistic as possible, and better yet, make them able to train other models in order for, let's say, classifying on patients' phenotypes or predict the patient responses to certain interventions. And this is something that is the open question for research. We have earlier evidences showing that it may actually outperform the original clinical notes in terms of the training those models. And I think other people have also reached similar observations. And this, I think, would be interesting not only in terms of the methodology exploration, but also in terms of operationalizing those large language models, because then you will be able to bypass those sort of this clinical, the institutional barriers, and have a really secure but effective way in terms of the sharing the information, sharing the models that you're trained with those with those data that is free of PHI and but still useful to a series of downstream tasks.
Thank you so much for the question. So we're just coming up to time. We have a light lunch we're going to invite everyone to stay around for if you can, but we have time for maybe one more question from the room. If anyone has a question they want to ask, a quick one. Otherwise, I'd like to wrap up maybe just with a quick, maybe more translational question, which is, what is your biggest translational success story, Yuan, either into clinical practice or into healthcare organizational administration, and why? What made that successful where, maybe other initiatives haven't quite made it yet?
Yeah, so I mean, there are many examples that come to my mind, and we over the past few years we have deployed the machine learning models into different clinical specialties, some including the cardiovascular disease that to predict patients' transition into advanced stage heart failure that are otherwise overlooked by primary care physician. So in those cases, we would actually alert the primary care physician. These patients really need to be evaluated at specialty cardiology office. And for some of those patients, they actually have left ventricular assisted devices planted in their heart and then saving their lives. And in other cases, we have deployed the phenotyping system in order to categorizing the multiple organ dysfunction syndrome in the pediatric intensive care unit. And there we were able to show that by characterizing those phenotypes, we can consistently identify the groups with the distinct disease progression and a way of interventions that would work consistently better on those identified subgroups. And also we have used this to inform the care coordination for the geriatric emergency department in order to predict who is going to need more care than the others, and especially after discharge, so that we can better inform the staff on care coordination. So all those examples, I think they're great demonstrations in terms of what we can do when we deploy the systems into the healthcare practice. And I think for the entire field, I think people are trying to operationalize this kind of deployment of AI system. One critical challenge is to take proper governance on those models and have the adequate standards that one needs to think about in order to make sure those models are not only safe and effective, but also equitable, that are benefiting patients from different socioeconomic stratas in an equitable way. And I wanted to insert a plugin here. So we are organizing a special collection for the Journal of Nature Partner Journal Digital Medicine, MPJ Digital Medicine, on AI governance in healthcare. And right now there is an open call for paper. And if you have interesting ideas or interesting stories, please feel free to submit to the journal and indicate in the special collection. And we look forward to receiving interesting stories and arguments or advocacies from you.
Great, thank you so much. So it falls to me to thank everyone for coming today and making time both online and in the room. Please do take up Yuan on his offer to contact him if anything that you've seen today sparks interest. And if you do have further questions, I'm sure he'd be happy to continue that conversation. Otherwise, please do stick around with us for lunch after the event. But please just join me in thanking Dr. Luo once again for great.
Thank you for having me.
Thanks so much.
Take care. Bye-bye.
Bye.